Hi everyone, I'm Rakshita Disanayaka. I, on behalf of Ananda College All Boys Association West Coast, in collaboration with East Coast, All Boys of Nalanda College, Royal College, and All Girls of Visakha Vidyalaya, Museus College, Bishop College, and St. Bridget Convent, would like to welcome all of you to the fourth Zoom presentation and discussion on the current crisis affecting all of us, COVID-19 virus. This indeed the worst crisis of our lifetime. This crisis has brought us all to a standstill. With a global death toll nearing 375,000 and deaths in United States surpassing 100,000, we no longer can work in isolation, but to a united front. In this sense, I would like to take this opportunity to thank the presidents of all the All Boys and the All Girls Association for their leadership to harness the awareness of the crisis among the community by working together. Our sincere thanks to all the guest speakers and to the Planning and Execution Committee of Acobawc West Coast. Special thanks to Colonel Lucky Rajasinghe for working tirelessly, creating and assembling all the program, and Tilanjan Vitana for creating a beautiful flyer, and to my wingman Rahim Mantara for the coordination. I'm sure that this kind of meeting will allow us to prepare better for the adversity we are facing today during this period. Now, I would like to introduce the moderator for today, Dr. Lasika Senaviratne. He is the Medical Director of Southern California Oncology Research Consortium and former Chief of Oncology and Chief of Medicine at the Good Samaritan Hospital in Los Angeles, California. Here is Dr. Lasika to lead the presentation and discussion. Thank you.
Good morning, ladies and gentlemen. My name is Dr. Lasika Senaviratne. I'm a medical oncologist and a hematologist in Los Angeles, California. I'm also an alumnus of Ananda College. I would like to thank all of you for joining us on a Saturday morning where we think we're going to have a wonderful, vibrant discussion on COVID-19. To say that we are living in an unprecedented time right now, I think not an exaggeration, ladies and gentlemen. We never saw this coming, that we would lead a life like this during our lifetime. None of us thought like. This COVID-19 has brought this world to a standstill. It's impacted not just lives, but it's also impacted livelihood. And hence the topic for today's discussion, COVID-19 and its impact on lives and livelihood. And this is just the part one, where we're going to talk about its impact on lives. We have put together an expert panel of discussants, speakers, who will talk to us about the varying aspects of health effects of this COVID-19. Now, some people may ask, why do we have to talk about it at this time? I think, ladies and gentlemen, we are at a very critical juncture of this pandemic. As we talk about reopening the economy, we are trying to get back to work. Our kids are trying to get back to school. I think there is a lot of uncertainty, a lot of questions in people's mind. And as we get back to society, I think it's imperative and it's very important that we as a community, as people, act responsibly so that we can mitigate any kind of adverse effects from reopening the economy. And for us to act responsibly and for us to act safely, I think knowledge is very important. Knowledge is very powerful. So we thought it's an opportune time for us to have this discussion, bring some experts to talk about the varying aspects of this COVID-19. As we reopen the economy, there are also a lot of theories out there that people have put out. We see that in mainstream, and we see that in social media every day. Some people say, oh, as the weather gets warmer, this thing will go away. Some people will say, oh, it's nothing but another flu. While some others have said, we are heading for the darkest winter in the history of US. We also have these questions as we get back to work. What will it do to flattening of the curve? Will there be a second wave? And if there is a second wave, what will it look like? How can we mitigate it? And also some people want to know, when will this end? So as there are a lot of theories and there is a lot of fear mongering, I think it's very important for us to know what is fact and what is myth. And that is one of the reasons why we thought we'll put together this panel to give us evidence-based facts and also to dispel some of the myths. To that effect, we have brought a cardiologist who will talk about the COVID and your heart. We brought a lung specialist, a pulmonologist, to talk about what it is like to take care of the sickest patients who have been afflicted with this disease and what we can do to take care of our lungs during this pandemic, how to stay healthy. And then comes that million-dollar question, when will we have a vaccine available? And to answer that, we have brought a scientist, a molecular biologist, who will talk to us about where we are in developing a vaccine. And last but not least, we brought a psychiatrist to talk to us about cabin fever. I think we all are going through that right now. So I hope during this 1 hour that we will be educated on all aspects, on varying aspects, on a broad array of health aspects of this COVID-19. A few housekeeping pointers. While the speakers are presenting, our host has put all of you on mute. And so there won't be any distractions, any background noise that will interrupt the speakers. But at the end of this speaker presentations, we hope to have a very robust question and answer discussion. I'm sure all of you are having burning questions that we can present to these panelists and get some answers. So while this meeting is going on, I would urge you to send in your questions to me. If you see at the bottom of the screen, there is an icon that says chat. So if you click on that, there is a chat box that opens up. By the way, ladies and gentlemen, this is the new norm, okay? This is how we're going to be doing business in the future. So So there is a chat box that will open up when you click on that chat icon. And there you can send in your questions. If you want to send it to the whole audience, you can do that to everyone. If not, at the bottom there is a little drop box. There's a little drop down where you can click and send it to me personally. And at the end of the session, we will take up all these questions and answers and present it to the speakers. So with that, I would like to invite our first speaker today. He's Dr. Rasi Wickramasinghe. He is also an alumnus of Ananda College, Colombo. He's an MD, PhD. He obtained that from Johns Hopkins University School of Medicine. He's currently an assistant professor of medicine and cardiology. And he's also the director of interventional cardiology and the director of translational research at Houston Methodist Hospital, Weill Cornell Medical College. And Rasi Wickramasinghe will talk to us about COVID and its impact on the heart. Over to you, Dr. Wickramasinghe.
Thank you. As Dr. Senivaratna said, I'm an interventional cardiologist by trade. And first of all, good afternoon from Houston. We're on different time zones. So let's get started. Lucky, could we have our first slide? So while we're going through the slides, let's start with our first slide. I want to just say, since I'm the one who's going to be starting this discussion, I want to get some things on the very outset on behalf of all the other speakers and sort of pull this together as one unified front. This discussion is not meant to be for doctors, it's for lay people. So we're going to try to take away and strip away all the big words that doctors use and try to explain it in a way that all of you who are non-medical professionals will understand. And we're trying to take a unified approach. So the first thing that we're trying to do, obviously, is join together a bunch of Sri Lankans from across America, and mission accomplished on that point. Number two, what we're trying to do is create a convenient excuse to disengage from our spouses on a Saturday morning. Believe me, I know I've done that because I told my wife, I'm sorry, I can't do any of the household work. I've got to speak on behalf of the old Anandans. And I'm sure all of you who need to do that can do that too. Number three, we're putting together what I call the collective Sri Lankan Brain Trust, a group of the smartest Sri Lankans, present company excluded, I will say, to educate other Sri Lankans on COVID better than probably Anthony Fauci can. And I know there are a lot of questions that you all have about this virus from all the news items that are going around. And this is going to be a good forum for you to ask those questions. Fourth, get all your questions about medical tweets that are going from certain individuals that will remain unnamed here, as well as conspiracy theories that are going in the media, all answered in one place. So if there's something that you're not sure, is this medically valid or not, this is the place to ask the questions, and we will do our best to answer them. And lastly, the purpose in all of this is to do two things, to educate and to entertain. Now, I will tell you, this slide was supposed to go one by one, so you weren't supposed to see the clown at the end, but let me make the analogy here. Education is something that comes naturally to us doctors. Entertaining is not. So having us as doctors trying to entertain you guys on a Saturday morning is like having a clown treat you for your illnesses. But that being said, let's move ahead and try to do the best we can. Next slide, please. So I want to start off by giving a brief overview, sort of a 35,000-foot view of coronavirus and COVID, and ask what is it that we're trying to do today, and why is this so important? Why is everybody freaking out about the coronavirus when we thought at the beginning of this year this was just like the flu? Well, this slide, which I call the roadmap of a killer virus, kind of makes that point. You see, every virus that we've had in human society, most of them at least, say the influenza virus, encephalitis virus, and so forth, attack one organ system and do it really well. What makes coronavirus much more scarier is that it attacks multiple organ systems and does all of that really well. So instead of attacking your lungs, it'll attack your heart, it'll attack your brain, your kidneys, your blood, your GI system, liver, and so forth, and it can wreak havoc in your entire body in one fell swoop. And this is the reason why coronavirus or COVID is also much more deadlier than influenza or other viral illnesses. So in this discussion, we're going to cover all of this. So I'm sure you all have heard, Wickramasinghes are known to be very smart people in Sri Lanka. Hell, we had a prime minister named Wickramasinghe. We had a famous author named Wickramasinghe. So in keeping with that tradition, Vikramasinghes are going to be handling the two most important organ systems in the body. I'm going to be talking about the heart, and Dr. Himanshu Vikramasinghe, he's no relative of mine, I promise, is going to talk about the lungs. And then you'll see that we have another panel of doctors who are going to be, Dr. Jayasen is going to be talking about vaccine development efforts that we heard. Dr. Mara Magay is going to talk about the psychiatric efforts, the psychiatric impact of this virus. And then Dr. Jayasekara and then Dr. Senivaratna are going to be on the back front moderating and answering more questions as the need arises. So we're going to try to take a 35,000 foot view and answer all these questions in one setting. Next slide, please. So with that being said, let me turn to why I think the heart is the most important organ in the body and why I think all of you, apart from all the other speakers, need to pay attention to me the most. And this is why. If you look at the risk factors that cause people to die from COVID-19, these are statistics from America. Out of 23,000, and currently it's about 32,000 COVID deaths that occurred in New York, 87% had at least one cardiovascular risk factors. In fact, next, Lucky. So you'll see here I've highlighted the top 10 risk factors for COVID deaths. So these are the risk factors people had if they died from COVID. You can see of those risk factors, out of the top 10, 6 of the 10 are cardiovascular risk factors. And as Sri Lankans, with our rice and curry and the type of food we try eating and the fact that we are not made for exercise and so forth, and our genetics, we have cardiovascular risk factors. I'm be surprised if you can find a Sri Lankan who doesn't have a single cardiovascular risk factor. And that is not good news for us, because that means more than lung disease, if you have cardiac risk factors like high blood pressure, high cholesterol, diabetes, atrial fibrillation, prior stents or heart, coronary artery disease, you've got to be much more careful at taking care of yourself from this, because the chance that you're going to get the virus is probably no different, but the chance that you're going to die from it if you catch the virus is much higher than the general population. Next slide. So before we get into the individual cardiac, I wanted to put this slide on to explain to you, going back to the original point, why I think this virus is dangerous and how does it attack all the different organs at the same time. It does so primarily because of a process called inflammation. And so for those of you here who are non-medical, who don't really understand what inflammation is, let me try to explain inflammation in a very nice analogy. So we just heard Rakshita speak and we heard Lasika speak. So I'm going to volunteer them for this analogy. So let's say I don't like Lasika and I want to punch him in the face. I obviously can't get close enough to him to punch him. So the easiest approach for me was going to be to tell Rakshita and get him worked up so that he goes and punches Lasika. Now take the analogy to the human body, okay? So the virus wants to wreak havoc in multiple organ systems and it cannot accomplish that. The easiest way it does so is by wreaking havoc in the immune system first. So the virus goes into your body, shows itself to the immune system. The immune system gets all worked up and revved up and starts attacking every single organ in the body. This is a very important point, because what this means is that the main driver of all the impacts of this virus in the cardiovascular system, in the lungs, in the kidneys and so forth, is not the virus itself, but the secondary effect that your body mounts as a result of having the virus, which is called inflammation. Okay, next slide. So let me start by talking about the 3 main things the virus does in the heart. So the first and most important thing is it actually causes heart attacks and strokes. How does it do that? We all know that most heart attacks and strokes are caused by plaque breaking off the coronary arteries. These are the arteries that are on top of the heart. A plaque breaks off the artery, a blood clot forms, blood flow to the artery stops, and the heart muscle that's provided for by that artery dies. Now we know that the most important cause of these plaques breaking off is having some degree of inflammation. So people who have inflammation like diabetics and so forth, they will have more heart attacks than the general population. Now you add to the fact that you have this virus, which has already revved up the immune system. And if you have diabetes on top of that, that means the chance that you're going to have causing heart disease is substantially higher. And therefore you see people with COVID developing heart attacks much more frequently. I'm sure you saw recently in the news, there was some data about even 30, 35-year-old people developing a massive number of strokes, and it's the same physiology. The inflammation causes plaque from the artery walls to break off, causing blood clots to form, and that's like a 1-2 punch causing heart attacks and strokes to be prevalent. Next slide. So the second mechanism that COVID attacks the heart is by something called COVID cardiomyopathy. Now that's a fancy word, and I promise you I'm not going to use big words, but let me explain what that is. So basically think of your heart as a pump. It's a muscle that pumps. So the strength of that pump is determined by how well that muscle can squeeze. So one of the things that happens is when the inflammation attacks the heart muscle becomes substantially weaker. So it cannot squeeze with the same power that it did before. You know, in usual terms, people know this as congestive heart failure. But guess what? The coronavirus can also precipitate congestive heart failure by attacking the heart directly. And this is something that we see a lot called COVID cardiomyopathy. In fact, in my experience, the vast majority of coronavirus patients who come to our hospital who eventually die from this don't die from anything else, but die from this heart failure at the very end stages. Next slide. So, and the last mechanism that the coronavirus attacks the heart is by triggering dangerous arrhythmias. When the virus penetrates the heart muscle, eventually after it starts circulating in the bloodstream, some of the attack it impinges on the heart, in addition to the inflammation that it causes the heart rhythm to get completely messed out of place. And that causes, you know, ultimately what you see here, which is having to put pads on somebody's chest and defibrillate them. And so this is yet another main reason how people die from the coronavirus. All right, so let's try to wrap this up. I think I made my 3 big points that I need to make. Lucky, can I have the last slide? Good. So the key point that I want to make is two prongs. The first is obviously, how does coronavirus impact the heart? And I think we've addressed that. It primarily increases the risk of heart disease and stroke by driving up inflammation. It causes this thing called COVID cardiomyopathy, a heart failure type syndrome that happens because of the virus attack. And it finally triggers a lot of arrhythmias in the heart. Now, this last slide sort of takes this picture back again and asks, why do we need to really worry about coronavirus? Lucky, I'm not seeing the slide again. All right, there we go. So the key point I'm trying to make is this is not the flu, folks. This is much more serious than the flu, and I want everyone to get that point into their heads. To date, we know that COVID has killed more people than the flu in less than 1/3 of the time, and that itself is a dangerous statistic. We know that if you have heart disease or heart disease risk factors, your risk of dying from COVID is even higher than having certain lung diseases. That's an important take home. The death rate is approximately 10 times that of the flu. It affects far more organ systems than the flu, and it is spread much more easily than the flu. And finally, most importantly, and we'll hopefully have some insights here, there's no cure for coronavirus, and there is no vaccine currently. So the bottom line is, please take it seriously and listen to your doctors. I'm going to be here at the end of this discussion to answer any questions that any of you may have. And for the time being, thank you very much. I'm going to turn this back over to Dr. Seneviratne.
Thank you, Dr. Rasi Wickramasinghe. Now, if that didn't wake you up on a Saturday morning, I don't know what would. That was such an animated, such an energetic talk. And if you keep doing things that he does and talk like what he does, you'll never get heart disease, I guess, Rasi. You gotta be so animated. Thank you so much. That was a really good presentation. And by the way, when I signed up for this to be the moderator, I never thought that I'll get punched in this whole thing. So that you never know what's coming your way. So anyway, thanks again. That was a very good presentation. I hope people enjoyed it. And I can see a lot of questions are coming in on the chat box. So that's good. Some are sending it privately to me. And just to let you know, ladies and gentlemen, we also have an infectious disease specialist on panel, our very own Dr. Deepthi Jayasekara, who will join later as a panelist for the question and answer session. So now that you know, you got all your heart pumped up, now let's take another deep breath and get our lungs filled up. And I would like to introduce our next speaker. Now, ladies and gentlemen, if you talk about somebody who's in the trenches, managing the sickest patients with COVID-19, the critically ill, he's our next speaker, ladies and gentlemen. He is he and the other intensivists who work in the ICUs are the last lifeline for these patients between life and death. When they're hanging by a thread, fighting for their lives, when they can't breathe, these are the people who take care of these patients. So my hats off to these intensivists who are working day and night, trying to save lives. I would like to bring on the next speaker. He's Dr. Himanshu Wickramasinghe, no relative of Rasi Wickramasinghe, as he had pointed out, but he's a relative of Martin Wickramasinghe. So there you go. He's an alumnus of Royal College as well as St. Thomas's College. So he's a hybrid. He is a consultant, pulmonary and a critical care, and an intensivist working at Henry Mayo Hospital in Santa Clarita, California. So over to Dr. Himanshu Wickramasinghe to talk about the challenges of managing the critically ill COVID-19 patient and intensivist perspective. Thank you, and over to you, Himanshu.
Good morning, ladies and gentlemen. I'd like to thank the organizing committee for inviting me, and I hope this information will be useful. So I'd like to cover 4 broad areas, basically. One is the common problems seen in the intensive care unit. The next would be challenges managing these very difficult and unique patients. Some of the treatment protocols and methods we've used, and also maybe a brief discussion of how we can get back to normal, now that everything seems to be quietening down. So basically, obviously this virus does attack the lungs, and so respiratory failure is one of the main features, and that's due to pneumonia, which is the infection from the virus itself attacking the cells in the lungs. But as Dr. Rasi Wickramasinghe has alluded, we also get this condition called a cytokine storm, and that's due to the immune response of the body sort of going into hyperdrive, and it produces these proteins called cytokines, amongst others, that when they're produced in excess and go into overdrive, destroy your own tissue. And one of the main organs that it destroys is the lungs, and produces a condition called the acute respiratory distress syndrome. And these patients are critically ill, pretty much at death's door. So the other thing that we sometimes see is shock, where their blood pressure goes down. Again, because it's a condition that affects so many organs, it can produce shock with low blood pressure that we have to support at times. It can cause liver injury, kidney injury, amongst other things. Then another common thing we've seen is blood clots. And patients who are in the intensive care unit, we have what are called DVTs, that's deep venous thrombosis, or blood clots in the veins of the arms and legs. And some of these break up and go into the lungs and block the blood vessels in the lungs and make it difficult to oxygenate, breathe, and actually cause respiratory failure and death. We see this a lot more commonly in patients who have COVID. Then one of the other unique things we've found in people who have COVID infection is actually mental changes, confusion, paranoia. One patient thought that we had kidnapped him and we were doing medical experiments on him. So this is also a unique feature we have seen in these patients. So these are basically CT scans of the chest. The one on the top left is a normal lung. The dark areas are normal lung tissue filled with air. What you see in the middle as white is the heart. The top right picture is one of a COVID area of COVID pneumonia that we count a ground glass opacity. The bottom left one is more severe involvement. We call this crazy paving pattern, and it's fairly typical. And then the last one on the bottom right is very severe involvement in a patient heading towards what I described as ARDS. So what are the challenges that we face in the ICU? Next slide, please. So basically, one of the major problems is that we don't have much data to treat these patients. We don't know the disease progression that well. We are learning more and more as we go along. There's no definite treatment for it. One of the biggest problems we face intensive care unit doctors is how do we best support the patient's breathing and their oxygenation. And if I can have the next slide with the methods of oxygen delivery, please. So here we have the methods of oxygenation for patients with lung problems that we commonly use in the intensive care unit. So it starts at the top left one, which is called a nasal cannula. That's the simplest. Then we go to a non-rebreather, which is a mask with a bag attached to it. Then we have what's called high flow oxygen. Then we have a non-invasive type of helping the patient breathe. We call that non-invasive ventilation. And then at the extreme, we have mechanical ventilation, where we have to put a tube down the patient's airway and windpipe and connect them to a life support breathing machine to help them breathe. So normally we can go through all of these steps to help patients with respiratory problems. But in COVID, we have this unique situation that because it's so continuous, two of the most important methods we use, one is the high flow and the non-invasive ventilator. We were instructed not to use this because data shows that this poses a very high risk to healthcare workers for the spread of the infection, because using high flow and non-invasive ventilation actually makes the patient breathe out a lot more of the air in their lungs, and it's a hazard to the healthcare workers treating them. So initially we found that we were actually going from regular oxygen and that non-rebreather mask straight to intubation, which is a pretty radical step. Later on, we sort of used the high flow more often, and it didn't seem to pose that much of an infection risk, but this was a big challenge for us. If I can have the previous slide, please. So the other challenges we've had are, it takes a lot of time to intubate these patients, and so that also poses a problem. Again, there's no proven treatment until recently, but even that treatment probably is not very helpful. We can discuss that later. Lack of adequate PPE is a real issue, and we've been using gowns, and that causes a lot of stress for healthcare workers. And there is a real fear of actually getting infected to take care of patients in the ICU, where you're exposed to these very sick patients. So the other problem we have faced in these patients is that, next slide please, the respiratory deterioration is very rapid. So one day you might find the patient on regular oxygen, and the next day you come in and they're already intubated and on mechanical ventilation. So deciding when to intubate these patients is a very difficult decision sometimes. One thing we have to think about is these patients are in isolation. They're in a separate room, and all the healthcare workers have to wear protective equipment to get into the room. So in an emergency, it could take a lot of time to get to the patient, and it can be too late. So we have to really think twice about when we're going to intubate these patients, so that we don't put them in danger. So that also has been a big challenge, and brings in a lot of stress. And one problem with intubation is it's one of the highest risks, not only to the patient, but to the healthcare workers, of getting exposed to the virus. And as you can understand, for all the healthcare workers in the ICU, this is physically and emotionally very exhausting. Another feature of these patients is that they take a long time to recover. They can stay on a ventilator for 2 to 3 weeks. And so that also puts a stress on healthcare resources and personnel. So what are the things that we found useful in treating these patients in the ICU? In the past, patients who have been in respiratory failure on mechanical ventilators, we have used this method of what we call proning. That means we keep them on their stomachs, laying down on their stomachs, and that improves oxygenation. But what we found in patients with COVID is that actually, even before they get intubated, when they're on regular oxygen, putting them in the prone position, getting them to sleep on the stomach, it improves their oxygenation, and we think it actually might speed up their recovery. So that's something unique we've been using, and I have a picture of that later on, which I will show. The other thing is we've already spoken about the cytokine storm, where these interleukin molecules are produced. One of the molecules that is increased in these patients is called interleukin-6. And there is a medication that's already in use that blocks the activity of the interleukin-6 molecule. And we have found actually that this medication called tocilizumab, or Actemra is the trade name, we feel that this actually helps these critically ill patients a lot. Personally, I feel that we have avoided intubation and life support ventilation in patients by using this medication, and we've got patients off the ventilator by using this medication. Then you probably heard about convalescent plasma. That's blood products we get from patients who have already had the infection, who have antibodies. We have a suspicion it works, and we have been using this. We need more research to know for sure if it helps. We have the antiviral medication, remdesivir. Again, it shows some benefit, but again, we're not sure exactly how useful it's going to be. It does not seem to be very helpful in patients who are very sick on ventilators. We have used steroids like methylprednisolone. We feel that this also helps in the more severe patients, and we are using this a lot. Blood thinners, because like I said, there are blood clots in these patients, and that can be life-threatening, so we have been using blood thinners. And then the other thing is avoiding giving these patients too much volume. That I mean by keeping the patients dry, because these patients have very leaky blood vessels and lung tissue. And if you give them too much volume, this leaks to their lungs and makes their condition worse. Next slide, please. So the next slide shows a patient in the prone position. The picture of a patient in a prone position. I'm not seeing the slide yet. That's it. So this is basically what a prone position looks like. And this actually helps these patients a lot, even before they get intubated. So I think I'll stop there because of time constraints. I do have some information on how we can get back to normalcy, but we'll probably reserve that for the question and answer session. Thank you.
Thank you, Himanshu, Dr. Himanshu Vikramasinghe. Next is Dr. Sumedha Jayasena. He's an alumnus of Nalanda College, and he is a PhD in molecular biology. He earned his doctorate from Lehigh University in Pennsylvania. He has been a former advisor to Amgen Pharmaceutical Oncology, and also he is a scientific director, and he's a molecular biologist by trade and an immunologist. So he's gonna try and update us and give us an answer, hopefully, as I said, to this million-dollar question: when will a vaccine be available? So Dr. Jayasena, over to you.
Thank you, Dr. Lasika. I think all of you are now in fear and startled. And it's my intention to give you all hope. And when we are talking about hope, hope drives life. And I'm going to give you a realistic hope when it comes to waiting for a vaccine. What is a vaccine? Vaccine is a biological agent that trains our immune system to recognize a specific pathogen, in this case, SARS-CoV-2 virus, and to mount an immune response against it. Part of the immune response is the production of antibodies to induce immunity. So immunity is to prevent infections, prevent the viral infection. So these antibodies have to bind to certain places of the virus to prevent that virus to get into human cells. So in the case of SARS-CoV-2 virus, these antibodies should bind to the spike protein that the virus uses to get into human cells. So these antibodies binding to spike proteins are called blocking antibodies or neutralizing antibodies. And in vaccine development, what we are looking for is the ability of a vaccine candidate to induce the production of this neutralizing or blocking antibodies. So there are several types of vaccines coming from different vaccine platforms, and the examples are shown here. So out of these platforms, what would be the best platform to produce or to come up with a vaccine that will be safe and effective for against the coronavirus? The answer is nobody knows. As a result, there are many, can I have the next? Next, thank you. As a result, many vaccine candidates are being pushed, derived from different vaccine platforms into the evaluation, hoping that at least several candidates will win the certification or the approval to be used as global vaccination. So why does it take, next slide please. Why does it take such a long time to produce a vaccine? Vaccine development is a risky business. It suffers from high financial risk and high loss of candidates during the vaccine development, high failure rates. So in order to minimize this risk and also to improve the safety and efficacy of vaccine candidates, a conventional approach is to take these candidates through in a sequential or stepwise process during the vaccine development scheme. However, the mandate, so that's the reason it takes such a long time. And currently it takes at least between 5 to 10 years to produce a vaccine for a new virus. However, in the past, it took more than a decade, several decades, sometimes in the case of chickenpox vaccine to be developed. The mandate given right now to develop a safe and effective vaccine against coronavirus, it stipulates that it should be done within 12 to 18 months. This is an unheard of and very unorthodox approach in terms of vaccine development time frame. So by crunching this time frame, will this fast-paced development compromise the safety of the vaccine that will emerge? We must understand that the vaccines are given to healthy individuals, not to sick individuals. And in this case, this vaccine will be given to all ages and across the globe. However, there are several proposals have been implemented even now in order to crunch this time frame. So these include, instead of doing sequential linear progression, have them done in parallel, in a staggered manner. So preclinical and phase 1 together, and phase 1 and phase 2 together. And in a vaccine development process, the longest clinical trials happen in phase 3. And in this case, the clinical trials are done in randomized fashion. You take the prospective human subjects, and one half will be given the fake vaccine, and the other half will be given the vaccine candidate. So the fake vaccine is also called the placebo. So in a normal, conventional way, these recipients of these shots will send out to their normal habitat. and let them expose in a natural way to the virus. But this will take several months to a year. So in order to cut down this even the phase 3 trial, it has been proposed to use human challenge trials. In this case, these human subjects who receive these shots will be challenged by live coronavirus. So by doing so, you can get the results very quickly within a month or so. And then usually regulatory reviews take up to a year, and this time will be slashed. So the other aspect to accommodate this crunch timeline is to bring the manufacturing process and facilities upfront, even at phase 2, before the phase 3 results are unveiled. This is also unorthodox. So the whole idea is to buy time and bringing advancing multiple vaccine candidates. Next slide, please. So there are 8 candidates already in clinical trials out of 107 confirmed vaccine candidates. And this effort is a public and private technological partnership, and the majority comes from pharma. And if you look at the distribution of these candidates, the lion's share comes from North America. And when we are selecting these winners, the safety, efficacy, and durability are the main characteristic to watch for. In addition, whether this platform could produce the vaccine in a rapid speed, and also whether the platform could scale it up to the global demand that will amount to a couple of billion doses of vaccines. And once this vaccine is available, it is going to be a global asset.
Alert from updates ready to install.
Oops. I think I lost. Hello.
No, we can hear you. Keep on going.
Okay, I can't see the screen though.
You can finish the talk now. Sumedha?
Sumedha, if you need some time, we can go to the next speaker. Can you? Is there any?
I can't see this. I can't see the screen.
That's okay. You can verbally finish it. Talk.
So just, slide is there now. Just
No.
closing remarks.
Okay. So let me sign out and come back.
All right. So until then, let me just give a little bit of punch points from what Sumedha has said, is that developing a vaccine is, ladies and gentlemen, not an easy task. First of all, the most important thing is the safety, because as he alluded to, you're giving this to a healthy population. So when you're giving something to a healthy population, you better not make them sick of the vaccine, and we better not have more dire consequences from the vaccine rather than the disease. So that's the most important thing. And that's where you do a phase 1 trial, is to look at the safety. Phase 2 is when you're looking for efficacy. And phase 3 is when you're comparing it with a non-vaccinated group. You have a vaccinated group, which is the control, and you have the non-vaccinated group, the vaccinated group will be your experimental group, and the non-vaccinated group will be your control. And then you want to make sure that the vaccine works by finding out that those who got the vaccine will not get the infection. That's a long, drawn-out process. And it takes years and years and years. So I think with the COVID-19, the important thing is that bringing these trials to like phase 3 in a very relatively quick time. Sumedha, are you ready?
Yeah, I'm back.
Okay.
Yeah.
All right. Over to you. Over to you.
Let me go back to where I was. So still I can't see the screen from Lucky. Okay, here you go. Go back, please. Okay. So I was here and building inventories early on that I touched upon. And this is a huge undertaking with a financial burden and economic risk. So in order to shoulder this financial burden, there are multiple players stepped up to the plate, and they are indicated here. Next slide, please. And the distribution of vaccine candidates in the clinical development space is shown at the top. And most of them are in the phase 1 space. And the phase 1-2 intersection is the Oxford AstraZeneca candidate. And the leading candidate is from CanSino Biologics. It is in phase 2. This is a Chinese company which is backed by Chinese military academic institutions. So by looking at this, we are already in phase 2 trials and crunching the timeline. And we are hopeful that a vaccine will be available beginning of the next year or in the middle of the next year. But there are reasons to believe that biologically we can have a vaccine against this coronavirus. And examples or the evidence come from the existence of neutralizing antibodies in humans who recovered from previous coronaviral infections. SARS-CoV-1, these antibodies have seen over 1 year period, and MERS-CoV, 2 years. And we know there are coronaviruses circulating among us, causing common cold. And for those coronaviruses, neutralizing antibodies have been found from several months to a year. And this indicates that we human beings can mount an immune response against a family of coronaviruses. That is very important. And then there is also evidence, as Himanshu spoke about, convalescent plasma therapy, and also the positive antibody tests. These tests are geared to detect neutralizing antibodies. These tests have been positive in individuals who recovered from COVID-19. And the other important aspect is no short-term reinfections of SARS-CoV-2 virus in humans within a month or so. And finally, there are reasons to be concerned. Most importantly, the first vaccine or several vaccines may not be ideal in terms of safety, efficacy, of duration. And this is my understanding by the, for the reason that it is done in very fast pace. So then this available vaccine, will that be a mandatory for every one of us to get? And will that provide us with an immune passport to roam around the world and then even to access our workplace environment? So even this is the opinion that I would like to share. Even if we get a safe and effective vaccine against the coronavirus, we cannot extinguish the virus from circulation among us. And this virus is going to stay over the next several decades and become the next newest member of the coronaviruses that cause common flu. And the vaccine that we have developed in the future will become the one of the components in the normal flu vaccine. However, having a safe and effective vaccine will help, will reduce the number of fatalities in the future. Thank you, and back to Dr. Lasika.
Thank you, Sumedha. I would like to apologize for the small glitches, technical glitches. Unfortunately, we are all in a learning curve still. This is the new norm. As I said at the beginning, We are experiencing a higher than normal, a higher participation than we had anticipated. So I think our meeting room is full. So if there are any technical glitches, please, bear with us. We apologize for that. Now we've saved the best for last, and that is we are bringing in a psychiatrist to talk about certain coping mechanisms. Living in lockdown is not easy. I mean, we human beings are social creatures. Isolation was a form of cruel punishment. Solitary confinement was given to prisoners as punishment. So most of us are enduring this thing called cabin fever. Of course, in Rasi's case, it's compounded by the fact that he has to keep talking to his wife. So I hope the next speaker will have some coping mechanisms for that as well, since a lot of people are having to engage in a dialogue with their spouses. So to talk to us, to educate us on cabin fever and some of the coping mechanisms, we have Dr. Kapila Marabage. He is also an alumnus of Ananda College. He is a assistant professor at University of Texas, Southwestern, UT Southwestern. He is the director of addiction psychiatry at UT Southwestern. Over to you, Kapila, to talk about COVID-19 isolation, cabin fever, and coping mechanisms.
Okay, thank you, Lasika, for the introduction, and thank you for involving psychiatry in this panel. I am an inpatient psychiatrist. I see a lot of inpatient situations right now, including some of which Dr. Himanshu Vikramsinghe pointed out, including delirium, confusion. There has been an upsurge of depression, anxiety, psychiatric symptoms, as well as drug and alcoholism, spiking up. So I am dealing with that, sometimes with COVID patients as well, who get delirious and confused and coming off of drugs and alcohol. But I wanted to tone this conversation down to more of a crowd that has been confined to home settings. So I wanted to highlight a few things. And if you can get to the first slide, Lucky. Thank you. So some of the things that set in as a result of disturbance in the social rhythm and activity, because we are now confined to home settings, we don't move around a lot, social rhythms are broken, and therefore fatigue and weight gain can sometimes set in. Sometimes because of lack of social cues and institutional cues, we are generally driven by those cues to keep our motivation at a high level and to keep our intellect at a high level, in certain professions at least. There can be reduced motivation and intellectual inertia setting in people. And then there can be depression, anger issues, irritabilities, anxiety that can set in as a result of confinement. And then so many stresses that have come along with the cabin fever, insecurity about jobs, insecurity about salaries, getting furloughed as such. And then also there can be emotional deprivation in the case of elderly who are confined to either, separate settings, and they cannot get regular visits from their children or their grandkids or something, and then that can cause emotional deprivation. And there is interpersonal tension and conflict, as Dr. Rasi pointed out, with your spouses, maybe with other people, with the kids. That it can be with your family, it can be with your work environment, the work crowd, because there is no separation of work and leisure spaces for us anymore. We work in the house, so there can be tension building up. Next slide, please. So in the next one, so those are the negative things that can happen in a nutshell. But there are some positive effects of isolation as well, if you want to look at it that way. You can discover insignificant strengths that you have had that you haven't paid attention to. You have the excitement of learning about unknown factors, about your spouses, about your children, how they function, their creativity, how they get along with each other, so many things. You can have the home comforts and facilities that are easily accessible as compared to work environments. So you are a little bit more cozy and you are familiar. You don't have to kind of, get dressed or something to work or whatever. And then, that kind of comforts will be there. There will be novelty and familiarity. You can find novelty in the routines that are in a familiar environment. You haven't, spent this much time at home. So now you can discover new things. You can do home improvement projects. You can do gardening projects as such. And then you can improvise. Even at your work, if you are working from home, there are ways to improvise without the accustomed restrictions that you might face at an office setting maybe. And there is a lot of free time, a little bit more free time, let's say, if you are working a lot from home for recreation, self-improvement, hobbies, exercise, and thinking. Then there can be a time out from the regular hassles of work, which these are all advantages, to some advantages at least, to being in a isolated situation. Next slide, please. And then I want to think about some positive attributes in that some people will survive cabin situations a little better than others. So we have done research related to Arctic explorations, space exploration, political imprisonments, and as such, there has been some papers that have come out. And there are some positive protective attributes to some people who survive this situation a little better than the others. And those are people who have low susceptibility to anxiety, depression, and emotional instability. What it means is that if you have baseline anxiety, depression, and emotional issues, psychiatric issues, then you are a little more susceptible to succumb to those. And we see those patients come into our clinics and our hospitals. And another good attribute is if you are introverted, that is, you are kind of, self-sufficient for the most part, but you are socially adept. You are like, introverted mostly, but you can handle social situations. And low demand for social support, and being sensitive to other people's needs and looking into your husband's needs or your wife's need and your children's needs and things of that nature. High tolerance of lack of stimulation. Some people can sustain themselves through music, through reading and exploring new subjects and things of that nature, and they don't get bored easily. That is a positive attribute in a person who can survive cabin fever. And low need for order, like, if you're kind of a OCD kind of person who requires a work rhythm or whatever, that you're very, without that you can get stressed. Next slide, please. So I want to come to this last slide. This is my last slide. I want to go through this rather fast, but it's important. I put in this word salutogenesis. It's a bit of a technical term. I wanted to stay away from any technical terms, but for the significance of its meaning, I thought I'll put it there. What it means is that it is the opposite of pathogenesis. In medicine, we talk about pathogenesis. Pathogenesis is the mechanics of an illness, like how an illness happens and how it manifests. And we went through so many things right now with Dr. Himanshu Wickramasinghe as well as Dr. Raj Wickramasinghe's presentation, how the pathology of COVID happens. So that is the pathogenesis. Salutogenesis is the opposite of that, where we will focus on how to prevent illness or derive a better situation. And this is like a favored subject in psychology and psychiatry. So how we turn around a bad situation into something good is what it means in plain language, positive outcomes. So how we do that is cooperativeness in work and play, creating family solidarity, getting into a family contract of assigning different roles to different family members would help us to get through this situation. And it gives us an opportunity to improve on relationships. So how do we do relationships? By creating something called social bubbles. We are used to being in our own bubble for the most part, and we are very kind of egocentric kind of society. Sometimes it happens so that way. So this is an opportunity to create social bubbles, and social bubbles can be created in two ways. You can do virtual bubbles versus physical bubbles. Virtual bubbles, we are quite familiar right now. We are doing Zoom and other social platforms, Facebook, whatever, and Microsoft Teams, that we hang out with our friends and people in Sri Lanka and all to make virtual bubbles. Physical bubbles is something that we are going into now, that we are coming out of quarantine a little bit. But when you do that, you have to make good rules, keep it to less than 10 people, trustworthy, who are like, share responsibility, maintain the social distance, and bring in entertainment into those groups. And then another thing that we can work on is improving health. Like Dr. Rasi, I think mentioned, Sri Lankans are not that much made for exercise and things like that. So being sedentary is not a good thing. Cardiovascular wise, respiratory wise, mentally also. Aerobic exercises, yoga is a real good thing. And right now there is an upsurge of, diet and, nutrition related activity. And reflection and contemplation, going for better goals, developing courage, developing self-esteem is important. And then the last thing I want to tell you is you need to try and change your thinking. And on this, I have talked about out-of-the-box thinking, which is a bigger, broader subject. You basically have to identify the box, the confinement that you are in mentally and in your work situations and in your educational situations. Define the box and try to expand the box or get outside the box of thinking. So that's in a nutshell what I wanted to talk about. And I wanted to give a positive message. This is not all bad. There are some good things about it. So maybe we can turn it into something beneficial to all of us. And there is, of course, hope down the pike. And then we have to get used to this kind of living for a little while. So it's better to kind of adjust ourselves around this COVID situation. So that is my message. And if there are any additional questions later, I'm very happy to answer. And I'll give it back to Lasika. Thank you.
Thank you, Kapila. Those were excellent presentations, ladies and gentlemen. That concludes our main program of the presentations. And now comes the most interesting part, I think, the question and answer session, where a lot of good questions have come our way. In fact, I am inundated with questions here that have come both on the chat, common chat group as well as the private chat groups. I've seen a lot of people from Sri Lanka asking questions, drawing comparisons of Sri Lanka to here. I have somebody from Helsinki asking a question and some privately asking questions, including on my cell phone. So at this point, I would like to bring in another speaker panel to the panel. He's an infectious disease specialist. He's Dr. Deepthi Jayasekara. He's also an alumnus of Ananda College. He's a clinical professor and a specialist in infectious disease, and also the chair of infectious disease at San Dimas Hospital and Kindred Medical Hospital. So we have a panelist, a panel of Rasi Wickramasinghe, cardiologist, Dr. Himanshu Wickramasinghe, a pulmonologist, Dr. Sumedha Jayasena, who is an immunologist, Dr. Kapila Marabage, a psychiatrist, and then of course we have Dr. Deepthi Jayasekara. So let's start the question and answer session, and please keep the questions coming in. The first question I got is actually a concerned mother asking, how safe is it when this reopens for our kids to go back to school, knowing that there is no real vaccine? And this is true for the daycare centers, the Montessoris, the schools, to the universities. How can we be assured that it is safe to send our kids back to school? I think since it's an infectious disease question, I'll direct it to Dr. Deepthi Jayasekara.
Hi, good morning, guys. Thank you. Those were excellent presentations, and believe it or not, I learned so much about COVID-19 and multi-system organ involvement. And thank you so much for being part of this. I'm going to jump right into questions, and please, the panelists also, please spend as least time as possible on the answers, and you guys can reach us. You guys know our cell phone numbers anytime after the talk. Okay. So the $1 million question that a lot of people ask us is, are we ready for reopenings? Are we ready to reopening the economy, such as schools, businesses, sports activities, and life in general? So let me put it in all this in perspective. Now, for the past 5 months or so, we've done immense amount of research And clinical trials, some of them are actually randomized clinical placebo-controlled clinical trials, right? So I'm proud to say that at this point, compared to early February, we are in a position to take care of our sickest patients. That's the bottom line. I'm also confident to say that 80% of the patients are asymptomatic patients. And in fact, out of all the patients, 80% out of the patients who have COVID-19, 80% of them are without symptoms or very mild symptoms. A recent WHO analysis showed, CDC analysis actually showed that 30% of us are asymptomatic carriers of the virus. So now that is scary. But going forward, I can give you the assurance and the confidence that that we have treatment protocols in place for patients who have mild to moderate to severe infections. So now we all know that the economy is barely trying to stay afloat at this point, and people are suffering, right? And this is not just a healthcare crisis, but also an economic tsunami. So I think we are ready to reopen the economy as long as we follow the guidelines set forth by the public health authorities. It is as simple as that. Now, bulk of the infections happening right now are as a result of exposure due to two things: exposure to a high viral load, right? High viral load from somebody who either have a mild, moderate, or severe infection, or other side of the spectrum is the fact that people don't take these mitigation steps that we lament about over and over again seriously. So those are the two ends that we see. So there's nothing you can do about the first one, because any of us, while taking all the preventative measures, can get exposed to somebody. In order to minimize a high viral load, in order to minimize that, we just have to make sure that we follow the protocols, simple protocols. Most effective one is actually, social distancing and wearing a mask, right? Wearing a mask. So wearing a mask will prevent you from touching your face, nose, and mouth, right? So going forward, if you actually open the economy, open the schools, we have to make sure that these two things happen, right? So are we ready? We are not ready at this point, but I think by July, August, September, we'll be ready to open the schools. The kids will have, we just have to follow the protocols set forth by the local public health authorities. That's number one, right? Number two, second question is, second question that we commonly asked is the fact that once you have an infection, what kind of treatment protocols do we have? Now, Himanshu actually went through most of the treatment protocols for severe patients. Even mild to moderate patients, we do have something that we call a simple strategy. Actually, I don't want to use medical terminology, but we do give them high-dose vitamin C, high-dose vitamin D, and zinc sulfate in order to mitigate your own immune system inflammatory reaction. And then some people prophylactically take hydroxychloroquine. I know there's a question about taking hydroxychloroquine, and then Sri Lanka is doing so well using hydroxychloroquine with minimum deaths. So I don't want to get into the political aspect of this, but I'm proud to say that if you take hydroxychloroquine in the proper way, if you do the risk assessment as a physician and give hydroxychloroquine to the proper people, proper patients, then it is life-saving. Those are mild to moderate patients. Severe patients, we do have the protocol. As Himanshu pointed out, we have the IL-6 inhibitor, we have convalescent plasma, we have the remdesivir, and other protocols. So that's where I would stop.
All right, thank you, Deepthi. In the interest of time, since we have lots of questions, let's move on. One of the, and I'm going to summarize some of these questions since there are, a lot of them are repetitive. One of the most commonly asked questions is, I think this will be mainly to Rasi and also to Himanshu. If you have high blood pressure or diabetes or any other high cholesterol, any other risk factors for heart disease, or if you have asthma, which is a chronic lung disease, But if they are well controlled, your diabetes is well controlled, you're taking your blood pressure medications, do you run the same risk of getting COVID-19 as opposed to somebody whose these medical conditions are not well controlled? So I'll open it up to both of you since it's a cardiac and a lung condition.
Okay, so I can take a stab at it first. So the answer is yes. If it is controlled, your risk of having the consequences of this are going to be lower, but it's not zero. So in other words, if you have diabetes that's well controlled on medications, your risk of having a complication from COVID-19 or dying from COVID-19 is less than someone who has uncontrolled diabetes, but it's still significantly higher than those who have no diabetes. So when we look at that New York study, as well as the data that initially came from China and looking at it, all of this showed that they didn't even make a distinction between whether you have controlled diabetes or not. They just asked people, do you have diabetes? Yes or no. If you have diabetes, you went into the diabetes category. If you didn't have diabetes, you went into the other category. But we've looked at this data a little bit more nuanced fashion, and we do see people who do have more controlled risk factors do generally better than people who don't. But the key takeaway is that by virtue of the fact that you just have that risk factor, your risk of dying from COVID-19 is going to be higher.
Himanshu?
Yes, I mean, just to add to that, yes, I agree with Dr. Rasi totally. And in the patients who are severely affected, I mean, we've actually had quite a few young patients. I know that, most of the patients who are affected by this in a serious way and who have a high death rate are the older patients, but we've had a fair number of young patients too. And we find that the common theme in these young patients, one thing that we've not mentioned is actually being overweight and obese. That seems to be a very big risk factor in these patients. And then, of course, the diabetes and high blood pressure. Initially, we thought that asthma was a high risk factor, but there's some that's come out, and even in the patients I've seen, asthma doesn't seem to be a huge risk factor. I'm sure it's more than somebody who doesn't have asthma, but it's not as bad as the risk factors of obesity, diabetes, and high blood pressure and cardiac disease.
Great, thank you. The next before that, there's a comment. Somebody had asked whether these presentations can be forwarded to them. He's actually a professor, he's a dean of a university who wants to know if these presentations and PowerPoints can be used for his teaching at his institutions, because he says that you guys have done a great job on this, that he's asking whether this will be available for presentations to other people. And I think the whole purpose of Ananda College alumni and all the other alumni associations doing this is for community service. So what's the point if you don't, spread the wealth and the knowledge? I think it is certainly possible, but of course these PowerPoint presentations are the personal properties of the speakers. So we will have all their emails available to you, and you can reach out to the speakers individually and ask them if they can share the slide presentations. And to the best of my knowledge, this program is being recorded. So if anybody who missed it wants to go back, I think it'll be available on our websites as well. Anyway, also I wanted to say there's a part 2 coming in about another month, and that's COVID-19 and its impact on livelihood. Today we're talking on the health aspects, but the next one will be on the economy and how it's impacting livelihood. That'll be, of course, not this panel. It'll be a different panel of experts who will speak on that. So stay tuned for that. So the next most common question I have got is about hydroxychloroquine. I mean, that's, I think, the most spoken medication. So I'm gonna open it up to Deepthi and Rasi. Please try to keep the answers as short as possible because we have so many questions. Is hydroxychloroquine, does it work? And what are the risks of taking it? And that goes also with chloroquine, its counterpart. Who wants to take it first?
Yeah. Yeah, let me go first. Hydroxychloroquine and chloroquine are great anti-malaria medications. This is going to be a lot of fun, right? So I'm gonna dive into it right away. Anti-malaria medication. Those are great anti-malaria medications until about 20 years ago, when Plasmodium vivax started developing, and Plasmodium non-vivax species started developing resistance. So we don't use that in malaria that much now because of the resistance. But we continue to use hydroxychloroquine as an anti-inflammatory agent in rheumatoid arthritis. Now, when out of desperation, China announced that we have had experience with hydroxychloroquine in SARS patients. So we all jumped in, we started using hydroxychloroquine in our patients. And there are three mechanisms of action by hydroxychloroquine. Number one, it's an anti-inflammatory agent. Number two, it's an immune modulatory agent. Number three, it enhances the pH of the cell membrane so that the fusion of the virus is inhibited. Fusion of it. So it's an antiviral medication as well, in a way, right? So how now, and it's a very inexpensive medication, and it's a time-honored medication. Safety profile-wise, there are so many studies that I evaluated hydroxychloroquine in their safety studies. So, but the Lancet study that involved about 9,000 patients came out from Harvard last week or week before, I believe, showed that it's not safe to use to be used in COVID-19 patients, right? Now, they focus mainly on cardiac risk and out of cardiac risk, ventricular arrhythmias, ventricular tachycardia, meaning arrhythmias, heart rhythm issues, and then that are dying due to heart rhythm issues, right? But before that, WHO had done a complete analysis through its something that we call a pharmacovigilance database that showed about 76,800 deaths, side effects due to hydroxychloroquine, and 607 deaths due to that. So obviously, we all knew about these side effects of hydroxychloroquine. So what we do, there have been a paradigm shift in the management of COVID-19 as of last 2 months, last month or so mostly. We don't use hydroxychloroquine on regular patients. We only use that on case-by-case basis. We have to do our risk assessment. It's a great medication if you do it right. And for prophylaxis, I think that has a place, but those randomized clinical trials, placebo control, are being done by NIH right now. Over to you, Russ.
All right, I'll just add very shortly to that. I think it's hard to add anything to that very comprehensive answer from Deepti, but basically, from the cardiac standpoint, as he pointed out, the two big consequences of hydroxychloroquine are something called the vacuolar cardiomyopathy, which is a heart failure that you rapidly develop, and the ventricular arrhythmias. Now, I will tell you, the arrhythmias are hard to predict, but the heart failure that you develop from hydroxychloroquine has nothing to do with the heart failure that most people have. Most Americans, most people, when they talk about congestive heart failure, have something called ischemic cardiomyopathy. That's because of blocked arteries. Hydroxychloroquine causing heart failure is a completely different issue altogether, and the risk of that happening is very, very, very small. But when it does happen, it's often rapidly progressive, it's often very serious, and in rare occasions, it can be fatal. So I don't think that, I think everyone talks about this because this is the most pronounced side effect of hydroxychloroquine. But as I think, if you use it on a case-by-case basis and you use it on the right sort of patients, I don't think it does much harm at all.
All right, so as the moderator, I need to go also on record to say that there is no good evidence to suggest that hydroxychloroquine works in all patients. So as of now, the WHO, the NIH have said not to take hydroxychloroquine. I guess you can use it on a case-by-case basis, but the consensus is that we should not be using it outside of a clinical trial, I would say, in a very, very controlled manner. Because you know that mail orders for hydroxychloroquine have escalated. People are just getting hydroxychloroquine, or more commonly chloroquine, which is very readily available in the third world. And they're just getting mail orders of chloroquine and hydroxychloroquine. Please, please, please don't do that, because the data is very, very, very controversial on this. So I think we have to be very scientific, and on a scientific forum, we have to give evidence-based medicine here and data. And right now, the data is not that hydroxychloroquine should be used. It should not be used. All right. The next question is on, I'm sorry, there are so many questions here. The value of aspirin in preventing these little blood clots, and also vitamin D. I'll put that to Rasi.
Sorry. So yes, so with respect to use of aspirin, right now what we have is just theoretical information. Nobody's actually done a clinical trial to see whether there is a reduction of blood clots with the use of aspirin. I think it's reasonable to assume that it does work, and I will put that as a highly qualified statement because I really don't have evidence for that. There's new trials looking at, one of the things I didn't talk about, one of the complications is blood clots developing not in the arterial side, but developing on the venous side. And there was a recent trial that actually looked at using anticoagulating agents, not aspirin. These are things like warfarin, Eliquis, Xarelto, Pradaxa, other high-intensity anticoagulating agents as a prophylactic measure against blood clots from COVID-19 once you are in the hospital. So understand that there are lots of layers of restrictions on this. This is not to say you should start taking one of those blood thinners at home to prevent COVID-19. No, it doesn't work. If you are in the hospital, then taking these blood thinners or putting those patients on blood thinners has been shown to reduce the impact from developing venous blood clots in most people. The data with aspirin is a little weak, but I think we have very good data from the cardiovascular standpoint that because of aspirin's anti-inflammatory properties as well as anti-thrombotic properties, you can prevent people from having heart disease. So I think it's reasonable to assume the same may probably be true for COVID, but if you have a risk of heart disease, most people should be on aspirin anyway. So I don't think we should be on aspirin whether there's COVID-19 or not. So I don't think you should take aspirin just because you're worried about COVID-19, but I would rather say if you have a risk of having heart disease, talk it over with your doctor, and you should probably be on aspirin, and that'll probably give you a little bit of an added protection. Thank you.
All right. Moving on to a different field now, vaccines. There's a lot of interest in vaccines as well. And this question actually comes from me to Sumedha, and others can chip in. Anthony Fauci, Dr. Fauci keeps calling this multiple shots at the goal, which means there are so many, there's never been a disease where the whole world has been working in unison, trying to come up with a vaccine and a good treatment regimen. So there are so many vaccines in development, and I think Sumedha touched on this. There's a vaccine from the Oxford group. There's a vaccine now that came, the Moderna vaccine that came recently. So these have different mechanisms. So if it would be nice if we have one vaccine, but what if there are multiple vaccines that come out with promise and have very good efficacy data? Let's say we have 2 or 3 vaccines. Then how do you sort out which vaccine to give a particular person or which vaccine to select? That's part 1 of my question. Part 2 is, let's say the first vaccine comes and we all go and we clamor and get that vaccine. And then later on, a better vaccine comes that's more efficacious. How, if you have already got that one vaccine, the first vaccine, can we get that second vaccine that is more efficacious? I would like to open it up to Sumedha and the panel.
Yes, Lasika, those are great questions. So it is likely that we will get a couple of vaccines approved. And so there are various aspects, not only the efficacy, but the ideal vaccine would be that will induce a strong immune response and only one shot. So you don't need booster shots. So these will come from live attenuated platform. So that's the most effective vaccine going to be. But if you talk about the Moderna, the mRNA-based vaccine, it will need secondary boost shots. So if you were to take the first vaccine, then getting the second vaccine may be not suitable, depending on whether you have the protection. You don't know the durability of the vaccine, right? And there's no time to even evaluate the durability of the vaccine. So so there should be clinical trials to evaluate whether the first vaccine efficacy is gone. So those who are getting the first shots of the first vaccine will automatically become clinical trial candidates, because they will produce the data. So that's one aspect. And the second aspect is this is a global asset, right? It should be given to all countries. So whether you can distribute them, do you need refrigeration, or can you do it at room temperature? So those are the other aspects.
Thank you. So the question is then, are we going to go and get the first vaccine that's out there that as soon as it comes on the market, or are we going to wait and see whether there's a better vaccine? I think nobody knows the answer right now. Okay, the next question.
Let me pitch in there a little bit. As an infectious disease specialist, we are vaccine specialists as well. We've given so many vaccines to mitigate so many diseases over the years. But the classic one, the most recent one, was HPV vaccine among kids, and has been very effective. And then the latest herpes zoster shingles vaccine, right? So having learned so much from the past vaccines, I think going forward we have a projection. Vaccines, certain diseases, we cannot come up with the effective vaccine. So pinning all our hopes on a vaccine is not the right way to go, guys. I'm sorry to disappoint you. Yes, there's so much work being done in that area, but we have to move on as if there will be no vaccine. That's how things are. That's why there are so many ongoing clinical trials. I'll give you a classic example. For the sickest patients with remdesivir treatment, there are other JAK1 and JAK2 other chemicals, anti-inflammatory chemicals, being trialed or tested. So that kind of things have to be looked into as effective treatment. So as it stands now, we don't hear much about an effective vaccine. Yes, Glaxo came out a couple of days ago, said that they're going to come up with 1 billion doses of vaccine by early next year. Now that's the best we've heard. Oxford Group have told us many times that they're going to have many millions of doses of vaccine towards the end of the year. All those are like murky statements out there. I think those are based on their hope and their, it's actually the kind of work that they put in, or the effort they put into to their trials, right? So going forward, my short answer is as if there's no vaccine. So you have to do everything right to protect ourselves. For malaria, I'll give you another example. Malaria, there's no vaccine. But what do we take? We do take treatment with something that we call chemoprophylaxis. We take Malarone tablets starting prior to the visit or travel, and then continuing throughout the day. Something like that. Something will come out, I'm pretty sure, as far as prophylaxis or prevention is concerned chemically, and then a vaccine will add to that as well.
All right, thank you. Thank you very much. So that's very, very good information. There's another very common thing that's coming up is the protectiveness of BCG vaccine. That's a very common theme that I have seen several people ask. Is the BCG, so for those of us who were born in Sri Lanka and grew up there, we got this vaccine called BCG, which is to protect against tuberculosis. This is for the non-Sri Lankans who are joining the platform today. So the BCG actually is being tried in Australia right now in clinical trials because they have seen a protective effect on that. Can, Deepti, maybe you can touch on that?
Sure, BCG vaccine is being tested right now at University of Melbourne, right? And they are into phase 2 and phase 3 trials already. So we have a lot of hope on that. But a lot of these big pharma companies are not talking about BCG vaccine because BCG vaccine is cheap, right? it's known to us from prior experience that BCG has been given as an immune modulator. It primes your immune system, right? So much so that if you develop a highly inflammatory disease, your BCG vaccine site gets inflamed, like red, like it's typically in the arm. So that shows it primes your inflammatory system, right? So it actually enhances the memory part of your immune system to fight a potential infection. That's one part of it. The other part is BCG vaccines given to treat early stage bladder cancer as well. And there are trials going on to treat early stage colon cancer. So as we know, BCG vaccine is not just to prevent childhood tuberculosis or metastatic tuberculosis or like a widespread miliary tuberculosis, but also for enhanced. So it has a lot of hope, a lot of promise. Only time will tell how BCG will come out. The data will come out from BCG clinical trial at University of North.
I think I should also reiterate what Dr. Deepti said about the vaccine. It's not that simple to come up with a vaccine. We've had HIV, for example, decades and decades, and we still haven't come up with a good vaccine for that. But also going hand in hand with that is also developing good treatment protocols. We have remdesivir, which was showing some promise, and then we have other antiviral agents. And so I think it's not just pinning all our hopes on the vaccine. If it works out, it's really good, but also developing other treatment strategies. Now I'm going to refer a question to Kapila, Dr. Marabage. So a lot of mothers and parents are homeschooling these days. The children are at home and they have to homeschool these kids. They have to also juggle their work. So while one is working, the other one is teaching the students, and that's caused a lot of stress, not just in parents, but also in children because of this homeschooling. Kapila, can you address that a little bit and some coping mechanisms?
Yeah, yes. In fact, we have seen, and I think it's reported research-wise also, that the stress levels among females, the women in the house, is a little higher than the men's, because they are the homekeepers for the most part. They take care of the house, they take care of their husbands, they take care of the cooking, they do a lot of work in the house. Now, in addition to that, they have to attend to some of the homeschooling. Of course, we expect the husbands to help out, but they are the bulk of the burden. And on top of that, if they have had to work from home also, it adds a lot of stress. It looks like the anxiety levels in the women is much higher than the men. And what I have found to be helpful is that, they take some time out, they have some time for themselves, and having a good structured protocol to conduct your work, to specify the school for a particular time of the day, and then to do it around your own work. There is no easy fix for this, but I think everybody in the family has to contribute. The husbands have to take on more work from their wives in order to make them a little more comfortable. And apart from that, if there is anything ongoing, like for example, if there is any anxiety, depression in the background, it's always good to be in touch with your providers. We have a lot of virtual visits with patients. At the clinic levels, we make sure that we make the virtual visits. We have video capability now. It has been approved. So be in touch with your providers or your therapists if there is an issue. And if there is no provider to go to, you can always reach out to the community hospitals and your primary care physicians to help out. This I'm talking about extreme cases, but I went through a certain mechanics. I think providing role play for different people in the family is going to be helpful. The single person is not going to take on the whole burden. To spread it out among adult children would be helpful. Taking some time for yourself, doing exercise, getting good sleep, having a good structure would help. I think that is what I would come out with.
Have you seen, Kapila, any escalation in domestic violence, child abuse? We know gun sales went up quite a bit, which was scary, but there are also reports of increase in domestic violence and child abuse.
Yeah, child abuse, I cannot tell you for sure. I don't deal with children's issues that much. I work in an adult hospital. I know for a fact there is significant increase in the domestic violence. And there is one thing, that there is frank domestic violence, and then there is also confinement of, like, let's say there was ongoing emotional abuse between a husband and a wife. Now they have gotten to be in the cabin together for a long duration, and there is a lot of escalation of stress and PTSD related symptoms even without domestic violence. And they cannot even have an outlet, because now they cannot, even if we do video conferencing with them, they cannot open out because the husband is next to them. So like if it's such a case, so it has given a lot of challenges both to the providers as well as the patients. There has been an escalation in PTSD symptoms.
Thank you. Yes, that's why I said these are unprecedented times, trying times. We are going a little bit over our time allocation, but I think there are so many questions. I hope people they will bear with us. The next question is actually again from on hydroxychloroquine. There have been some reports apparently of respiratory failure. Can Himanshu address that about hydroxychloroquine and its impact on the heart? I'm sorry, on the lungs?
Yes, so there were 2 studies that actually came out where they used hydroxychloroquine, and they found that patients who were on hydroxychloroquine were more likely to go into respiratory failure. They had more bad outcomes from a respiratory standpoint. So I think, that also needs to be borne in mind, especially when the patients are having bad pneumonia and respiratory failure. So like you already said, Lasika, I think, the jury is still out. We need to wait for better studies on hydroxychloroquine before we can advocate either for prophylaxis or for treatment.
Thank you. The next question is on overcrowding. This comes from the United Arab Emirates. So we are very, very happy that people are joining in from all over the world. So there is a situation, again, a lot of Sri Lankans who live there, who are living in crowded spaces, and they're they're workers. They're sharing maybe a flat or an apartment. So in those situations where there is a lot of overcrowding, if one person gets infected with this virus, how do you try and intervene to make sure that this virus doesn't get to the other people? I think this has an implication for us here as well. As we reopen, people are talking about reopening the hair salons, the nail salons, the restaurants, So I think overcrowding is a concept in different formats. In the US, it's in restaurants. In the United Arab Emirates, it's because people are sharing a lot of, a common space. So how can we mitigate if you're living in crowded places, or if you're going into very, closed spaces? What is the risk of, if one person has it, of it spreading? I will open it up to the panel.
So I'll take that question. I think Dr. Deborah Burks recently told us, right, and she was very clear on this when she was addressing reopening the economy, reopening schools and sports activities, everything. You make sure if there's no room for social distancing, you wear a mask. I think that's the essence of the mitigation strategy going forward, right? There's no room or no space for social distancing more than 6 feet. You have to wear a mask. So it's as simple as that. But having said this, there are so many countries who have done this by religiously following public health guidelines. So I think all of us, those who are concerned, especially those who are concerned about reopening economy, have to go through these local, regional public health guidelines, line by line, statement by statement, and come to terms with the mitigation steps. Very, very simple mitigation steps, but they have to be monitored over and over again. Now, if you are living in, and there's a recent study that shows, if you are living in kind of small apartments, houses, or working in those areas, there's a lot of us, especially household situations, we don't tend to wear masks. But what they recommend, what this particular study recommended was wearing masks inside the house. I don't know how practical that is though, but it is what it is. We just have to think of the common mitigation steps that have been, reiterated over and over again. That's the best answer I can come up with.
All right, so there is another concept out there, and there is a question about that. And that is, so there are only two ways in which we can get this virus out of this causing this pandemic. If for the virus to thrive, you have to have enough people for the virus to infect. There has to be enough human bodies that are susceptible to the virus, that the virus can then attack that body and start doing its thing. So ultimately, if we develop enough immunity to this virus, the virus will not have enough human bodies to get into and thrive. And that's the day that this virus will go away. So there are two concepts or two ways of doing that. One is through immunization. We talked about it. But some other countries have taken the step of what we call herd immunity. Don't lock down, go out there, party, do everything you can so that people will get this virus, some will die, and some will develop immunity. And eventually, if enough people get this immunity, this virus will go away. So that's called herd immunity. And I know some countries have done that. And the other one is called immunity through immunizations. Now, Deepthi, you just said, don't hang your hat on the a vaccine coming out quickly, and we don't know how effective it is. So what about herd immunity?
Yeah, so the herd immunity, this virus needs to infect at least 60% of the population to make
world population, right? The world population, 60%.
Yeah, no, it depends on the community. So if you are in isolated, let's say in an island, right? So then that community, yes. So if you are talking about the globe, yes, the entire globe population. But so you cannot left any population behind without this herd creating herd immunity. That will be a problem. It will serve as a reservoir for the virus to come out. So the herd immunity can be achieved by vaccination or natural infection, right? So 60% of US population is huge. And right now it is estimated that this current virus has infected between 20 to 25% of US population with over 100,000 deaths. So now you can imagine if you extrapolate this, what kind of death toll we will encounter. So one way to go about it by creating herd immunity that Sweden is trying it, but spikes are coming up.
Yeah.
Sweden, I think a lot of people talk about Sweden, but if you look at the statistics, compare Sweden to a country that's similar, like Norway. And, Sweden has only twice the population of Norway, but it has 10 times the death rate as Norway. So, this concept of herd immunity, I think, is not really very valid because like Dr. Smith has already said, you're going to have so many more deaths. In numbers wise, Sweden, it looks like, okay, like 2,000, 3,000 deaths, but actually you compare to a country like Norway, it's 10 times the death rate. So, and the other problem is that immunity from COVID, we don't know whether it's actual protective immunity. You have antibodies, but I think we still need more research and data to know whether this is actually going to protect us from future infection.
Yeah, that's true, Himanshu. So let me add to that very quickly. That leads us on to antibody testing, right? In order to test immunity, we need to have good antibody testing. So far, the antibody tests available by Abbott and Roche and other companies only tell us, and of course Cellex, that's a big company, only tell us whether you have IgG, IgM, or IgA against this virus. But that does not tell us whether those IgG, especially the IgG antibodies, are neutralizing or not. So that's the most important thing, right? So vaccines will help us to build up herd immunity. And as Sumedha pointed out, we have to have at least 60% herd immunity in order to mitigate the virus in the future. But don't forget the fact that this virus is mutating. As we speak, there have been about 17 strains, right, worldwide. So classic examples, influenza vaccine, right? If the virus turns out to be a virus like influenza with seasonal patterns, then we should have a vaccine that is developed based on the seasonal patterns. So Northern Hemisphere, we look at the immediately preceding Southern Hemisphere strains and produce those 4 strains, like we call it, tetravalent influenza vaccine, something like that, right? So going back to herd immunity, I think it's just a concept at this point. We cannot pin all our hopes on herd immunity. And that's all we could come up with at this point about herd immunity.
Okay. The next question is actually a little different. Without talking about all these disease, how to treat the disease without waiting for you to get the disease, there's a question that says, how can we discuss some proactive measures that we can take, like diet and exercise, apart from the social distancing and touching your face and all that? What else can we do? Is vitamin D helpful? Is zinc helpful? What are the other proactive measures we can take to mitigate this?
So again, vitamin C, vitamin D, and zinc sulfate have been shown by many scientists, many groups, to be effective in boosting your immunity, right? When you take vitamin C, I would recommend at least 100 milligrams, 1,000 milligrams. When you take vitamin D, we are talking about 5,000 international units of vitamin D3. When you take zinc sulfate, I would recommend 220 milligrams of. So those are the standard doses that we go by. But there are no clinical trials to prove that. In other words, there should be prospective trials showing placebo-controlled trials showing that the group that did not take vitamin C, vitamin D, or zinc sulfate are going to do worse than the other group, right? But of course, we do what we can under the circumstances. Things like simple, strategies like, or simple measures like, taking hot tea with ginger, right, and turmeric are known to cause some immune modulation in the body, right? So those are the simple things that we can do in order to uplift the hope, right, that you will not get a bad disease. That's all we could do under the circumstances. Guys, this is a pandemic, right? Obviously, when there's a pandemic going on, you have to do 150% in order to mitigate your chances of getting the disease. So hope is the only one that we have going forward, right? If there's a second wave, if there are recurrent seasonal patterns, right? But maybe Kapila can expand on this. So you should not kill anybody's hope in their mind, because that itself can bring down the immunity.
Yeah, absolutely. I completely agree with that, because emotional stability and depression, anxiety plays a huge role into inflammatory to depression, anxiety, stress levels. So it is counterproductive to become anxious and depressed over this. And one thing about the vitamin D situation that I learned recently through one of these forums itself that I took part in is that vitamin D supplements orally, like Dr. Jayasekara said, is important, but then exposure to sunlight is also important, like about at least half an hour in the morning between 8 to 12. If you can expose yourself to sunlight, the darker the skin, the absorption is less, the fairer the skin is better. But even then, to expose yourself and your children to sunlight in the morning, at least for half an hour a day, would be beneficial to build your vitamin D levels. That would be helpful. But then emotionally, we need to be stable as well, because this is a long drawn out problem. It's not going to end anytime soon. So we better get used to a life around it.
All right, the next question is directed at Rasi. These are questions sent privately to me. One patient has a prosthetic heart valve, so which means their heart valves have been replaced. And so the question is, can COVID-19 cause infection of the heart valves, which is endocarditis? And the second one is a very similar question. He says, I'm a heart transplant patient. Risks, and what can I do to mitigate this?
Yeah, so let me take the first question out with there. So with respect to endocarditis, we don't have any evidence of COVID causing any endocarditis in the heart valves. There has been maybe 1 or 2 cases of people developing infective endocarditis, found to be bacterial endocarditis, but now we think those are obviously super infections in the presence of COVID-19 rather than because of COVID-19 itself. Now, the one thing that people who have artificial, especially if it's a mechanical heart valve, that they need to be mindful of is that because of the inflammatory state, we have noticed a substantially higher proportion of these mechanical valves thrombose or clot off when you have COVID. That's to be expected. When you have COVID, you have a massive inflammatory reaction. Your entire immune system is revved up. Clots can form anywhere. And having a metal hardware inside your heart is the best place for that. So we see that much more frequently. So if you are someone who has a metal or a mechanical heart valve, my suggestion would be you got to be very, very certain that your anticoagulation is managed much more carefully and that you're within that goal because you have less wiggle room. Then with respect to the other question about transplant, I have bad news, and that is if you are a transplant patient, whether it's your heart, liver, kidney, or whatever, it's not the heart transplant that puts you at risk. It's the fact that you had a transplant and therefore are on immunomodulator therapy. And that increases the propensity we've seen across the board of developing COVID-related complications. So patients who have heart transplant, for example, our heart transplant clinics completely closed down because we were doing everybody remotely, even if they insisted on coming to see us, because the risk of having them come to the hospital was so high. So for heart transplant patients, I would say you need to take extra precautions with social distancing and mask wearing. But for the rest of patients, I think, you can take the normal precautions that we've been talking about.
All right. I have got permission from the host to go a little bit over time. We are already over the time limit. But I think there's still a very good attendance. People are logged in, and there are so many questions coming in. The other one is there any data on certain gene pools that are more resistant or vice versa, that are more susceptible to this disease in comparison to others? Is there any evidence of any genetic predisposition or resistance to this virus?
So far there is no evidence, but in the future there will be a lot of reports on susceptibility, genetic susceptibility towards the COVID-19 disease, and not the capability of the virus getting in. Because it is now, I want to mention that this virus is using 2 different receptors, CD147 on immune cells as well as ACE2 receptor.
All right. So
even though there may not be gene susceptibility, we do know that certain ethnic groups are more prone to it. For instance, the Hispanics, the African Americans, Native Americans, and actually even possibly some South Asians. So whether that's due to genes or whether it's due to work environments, living conditions, it's not clear yet, but there definitely could be a genetic component too.
Yeah, that's a great point, Himanshu. I think we have noticed that over and over again, right? Going forward, the targeted populations are sadly, there's a disproportionately high number in small like minorities, right? Such as Hispanic population and African American. Now, is that solely because of not taking things lightly or having so many risk factors versus genetic predisposition? We still don't know. But going forward, I think we have to do more studies in this regard, and there will be many more studies coming up with these results. Blood types are also important. I think some people and some studies have shown that blood type group A is more susceptible, and also they respond very well to the antibodies also. So that kind of things are there. So predisposing conditions, risk factors, we don't have a firm handle on these things at this point. But having said all this, I have to tell you now, I've had 500 patients as of yesterday, with 20 deaths in my eminent hospitals, 3 hospitals, about 1,000 patients altogether in the hospitals that we cover, about 10. So with that knowledge, I can say that our patients with HIV and our transplant patients and our immunocompromised patients have done extremely well, guys. That's great news. I think part of the reason is that they take this advice very seriously and they follow these guidelines, the mitigation steps very, very seriously. I think that is heartily news, right? The ones that are not doing well are the morbidly obese patients. That's a huge risk factor. And then people who are in their 40s, 50s, and 60s who have completely neglected their health.
Okay, I think in the interest of time now, I think we can wrap it up. But there are so many other questions that I think if you haven't had your question answered, you can reach out to the panelists. We will have their names and email numbers, email addresses available, so you can individually reach out to them. Ladies and gentlemen, as I said, this is just the part one. We do have another aspect of COVID-19, and that'll be part two. As you can see, the topic was COVID-19 and its impact on lives and livelihood. The livelihood part, which is mainly the economy, will be on June the 28th. And it's a very well-renowned speaker from England. His name is Ian Shepherdson, a renowned British economist and one of the best in the world for forecasting depressions and how to manage your finances through these great depressions, and how we can strategize our investments. I think as much as we're talking about our health, we also have to find out, are we going into a Great Depression? If so, what can we do to save for those rainy days? So I think that's why we said lives and livelihood of people. So I hope you will again tune in on June 28th. I believe that's a Saturday. You can check your calendars. We will have another email blast for you guys at 10 o'clock Pacific time. Once again, let me thank all the speakers, the panelists. Oh my gosh, they were really, really good. I'm sure our audience will agree with me. And when you say that they were very good speakers, very dynamic, very informative. And I hope that you guys have learned something. This was spearheaded by the Ananda College Alumni Association, but we did have a lot of support from some of the other alumni schools. We had Nalanda, we had Bishops, we had St. Bridget's, we had Museus, and we had Visakha, the schools collaborating with us to make this event a success. My special thanks to Colonel Lucky Rajasinghe, who spearheaded this whole thing. The technical part, it's not easy to put this together. And also to our president of Acobawc West Coast, Rakshita, and also Rakshita Disanayake, and then also to Rahim Mantara for his valuable support. And to the whole Acobawc West Coast panel. And I also want to acknowledge the East Coast Anandians for also collaborating and joining. So I hope you enjoyed this, ladies and gentlemen. So thank you once again for spending this Saturday morning with us. For some of you, it's Saturday evening. For some of them in Helsinki, who knows what it is, the time. In Sri Lanka, it's midnight. So thanks again, and have a wonderful, wonderful rest of the weekend. And please be safe. Get some of the advice you got from our panelists today and put it to use. Thanks again.